Okay, so we are still on the health insurance chapter, and hopefully today we are going to cover this whole chapter, and then you will have some review questions on health insurance. So your next exam, of course, health insurance is an important part of this. So let's go ahead and get started. So last time we spoke about, last two classes we have been speaking about why people buy health insurance, right? What is the way in which the price of health insurance, that is premiums in the market, gets set, right? Thirdly, we talked about the two most important phenomena in the health insurance market, which is moral hazard and adverse selection. Then we talked about ways that you can address those two issues, that is ways in which you can mitigate moral hazard, ways in which you can mitigate adverse selection. But then we said that the bottom line is you can never come up with a way which entirely solves those two problems. There can only be ways which restrict or reduce those problems in the health insurance market. Then we talked about employer provided health insurance, and we said that employer provided health insurance was one possible way to address the issue of adverse selection, but it does come with its share of disadvantages also, right? That is where we stopped. Now today we are going to talk about integration between the insurance company or the third party providers, integration between the insurance company and providers. By providers, of course, I mean the healthcare providers. Okay, so now you know, and we have spoken about this several times, that the insurance company enters into a negotiation with these healthcare providers, right? So the way this insurance market works is that the health insurance company is kind of in the middle, right? On one side, there are the consumers or the patients who pay a premium to the health insurance company. On the other side, you have the healthcare providers who negotiate a price with the health insurance company for whatever services they provide to the patients. So in some sense, the health insurance company is like a mediator. So they are kind of setting two prices simultaneously. In any other market, for example, the market for ice creams, they are not setting two prices at the same time. The sellers of ice cream, they are not setting two prices. They are just selling one price, which is the price at which a consumer would buy that ice cream, the market price. But in the health insurance market, this is also a difference in the health insurance market that you see compared to any other market, is that there are two prices being set simultaneously. One is the price that the consumer will face, which is also called the premium. The other is the price which will be paid to the healthcare provider. In other words, that is the negotiated price, right? So while the health insurance company is doing some kind of reaching an agreement with the consumer, that means while the health insurance company is trying to strike an equilibrium with the patient, they are also trying to strike an equilibrium with the healthcare provider, right? So you have two crosses involved there. One cross, demand and supply between the patient and the health insurance company, right? Where the patient is the buyer and the health insurance company is the seller. And you have another cross, demand and supply, between health insurance company and the healthcare provider, where the health insurance company is the buyer and the healthcare provider is the seller of his services. Do you agree? Yes? Okay. So that is also a unique feature. Now we are talking about, so far we were talking about the left hand side of that diagram, where the health insurance company was selling the health insurance and the patients were buying the health insurance, and the price that was getting determined was the premium. Okay. Now we are talking about the other side, which is between the health insurance company and the healthcare provider. Here the health insurance company tries to buy the services of the provider, and the provider tries to sell his services, and both of them try to negotiate a price. Okay. That is also called the negotiated price. Sometimes it is called the reimbursement rate. It is, there are different terminologies that can be used for that. Now we will not go into the exact details of how the reimbursement rate is set, because that is a mathematical kind of calculation. So we will not go into the math of that, but we will see that what are the kind of negotiations that can take place between the health insurance company and a healthcare provider. Okay? So, there are three types of negotiations or three types of settlements that can take place between the health insurance company and a healthcare provider. The first one is where these two companies are just separate entities, not companies, sorry, the health insurance company and the healthcare provider. They are two separate entities. That means the health insurance company has its own set of objectives and the healthcare provider has his own set of objectives. There is no integration. So, that means there is zero integration. Zero integration between the two. Okay? They have their own set of objectives. The health insurance company is only driven by its own profit motive. The healthcare provider is driven by his own profit motive. The only linkage between them is that the person, the patient is paying a premium to the health insurance company, and in turn the patient is receiving some care from the healthcare provider, and in return of the care that the healthcare provider gives to the patient, he receives some payment from the health insurance company. So, the only thing that is happening here is a channel. So, you have the patient who pays the premium to the health insurance company. There is the healthcare provider who provides the services to the patients, and in return of these services, they receive a certain price, certain negotiated price from the health insurance company. Okay? That's the only thing that is happening. Now, which provider the patient wants to go to, which healthcare provider the patient chooses, that is entirely the decision of the patient. The health insurance company has no say whatsoever in the choice of the healthcare provider. So, I can go to whichever doctor, whichever surgeon, whichever hospital I want to. The health insurance company has no say whatsoever. Okay? So, this kind of integration or this kind of zero integration is also known as indemnity plans. It's called indemnity plans, or it is also called fee for service, FFS, fee for service. That means you pay a premium, and in return the health insurance company has some terms and conditions for you, and you just get reimbursed for whichever doctor you went to, whatever services you got offered. And if the terms and conditions are such that you get paid for, let's say, 80% of the cost, then you just get paid for that cost and the remaining just goes out of your pocket, as simple as that. Okay? The health insurance company has no other role. The second one is known as selective contracting. Okay. Now, here in selective contracting, compared to the first one, the health insurance company has a relatively more active role. So, that's the difference between the two. Between the first one, the separate entities, and the second one, that is selective contracting, in the second case, the health insurance company gradually starts playing a little more active role. And what is that active role of the company? The active role of the health insurance company is that now they try to create a supply of patients for the healthcare providers. So, they not only negotiate the price with the healthcare providers, but they also try to channel or streamline patients towards a certain group of healthcare providers. In other words, they try to maintain a steady supply of patients towards these healthcare providers. Okay? So, here the health insurance company channelizes or steers patients towards a selected group of providers. So you can understand that that is a benefit for the providers. Now they don't have to go seeking out for patients. They know that the health insurance company will keep providing them with a steady flow of patients, right? Consumers will keep coming to them all the time because there is this middleman health insurance company which is ensuring that. So the healthcare provider must also offer some benefit to the health insurance company, must give back something in return. And what do they give back? They give back a lower negotiated price. Okay. So it's like a win-win situation for the health insurance company and for the healthcare provider. The benefit that the healthcare provider gets is that they have a steady flow of patients coming their way, and the benefit that the health insurance company gets in return is that they get a lower negotiated price from the healthcare provider. Now, does that have anything to do with the premium that the health insurance company charges the patients? Usually no, because in such cases the health insurance company keeps charging the high premium from the patients and has a lower negotiated price with the provider so that their profit margin is wider. So they are getting a high price from the consumers, the patients, but they are having to pay out lower prices to the healthcare providers, and as a result they are able to retain a larger share of that money and make a larger profit. Okay. Now in USA traditionally these were the two systems that were more common, the fee for service plan and the selective contracting plan. So can you tell me, is this a very good situation from the perspective of us patients? No, right? And what is the disadvantage or what is the major problem of these two plans, do you think? Sorry?
The patients don't really have an input. Yeah, you don't have high costs for patients.
So that means there will be escalating healthcare costs for the patients under these two systems. Right? There is no benefit, there is no direct benefit for the patients. It's a settlement between the healthcare provider and the health insurance company, and it lands them in a win-win situation. But for the patients, there is no takeaway. So the patients are at the receiving end, and they are receiving end of escalating healthcare costs. So obviously these are not two good things to deal with. So there must be something else which kind of cures or addresses that problem of very high healthcare cost. That third system is known as, which kind of tries to solve the problem of healthcare costs, is known as vertical integration. Vertical integration. Now what is vertical integration? Vertical integration is when there is maximum collaboration, when there is maximum integration between the healthcare provider and the insurance company, but at the same time there is some benefit for the patients. Okay. So in vertical integration what happens is there is a separate organization, usually an organization is formed okay, and within this organization, within this same organization, you have two parts. One is the health insurance provider, or I cannot call it a health insurance company anymore because it's no longer a company, it's like a department within one company. So there is a health insurance providing department and there is a healthcare providing department. So there is one health insurance provider and there is one health care provider, but they are both part of the same parent organization. Okay. So as soon as they are part of the same parent organization, you can understand that these two guys, the health insurance provider and the health care provider, they have a common set of goals and objectives because they are both under the umbrella of the same company. So the terms, conditions, motivations, objectives, they are all similar in terms of how they should set the price or what kind of quality of care they should provide. They are driven by one particular motive. Okay? This is the key feature of what is known as a managed care organization, MCO. So vertical integration, in another word, is the formation of a managed care organization. And what is a managed care organization? A managed care organization is any such organization which has two distinct divisions, one that provides health insurance, the other that provides health care. But both these divisions are driven by the same set of goals and same set of objectives and same set of motivation. So they are trying to fulfill the same things. Okay? And same things, by same things I mean what kind of price they should charge and what quality of care they should be providing to the patients. Okay? Now based on, okay, so when I started I said, okay fine, this vertical integration, any questions?
I'm just gonna, to me that seems like they could get together and go against the patients to maximize the profitability.
Yes, so your question will be answered just now, what I'm going to say right now. Okay, so in a way this seems like he said, like Brad said that, Brad, right? In a way he is correct when he says that this looks, if they are integrating so much and they are becoming the part of an organization, then this MCO must be able to get the better of patients. They should be able to exploit the patients even more, right? And that possibility is also there. But while they are able to integrate so much, when I started, I said that this vertical integration, the objective of this vertical integration was to find an answer to the problem that resulted from the first two, which was higher healthcare costs. So obviously, while these two are integrating, there must be something for the patients also. Okay? That something for the patients is usually, in a managed care organization, there is a fixed rate, and by rate I mean the rate of premium, a fixed rate charged from the patients drawn from a fixed population. So what am I trying to say? I'm trying to say that when a managed care organization is formed, when that kind of integration between a health insurance company and healthcare providers takes place, then such an organization is not catering to a very large population. As in, you cannot have a managed care organization that would cater to entire USA. Or you would never have a managed care organization that would cater to the entire state of Missouri. Or you would never have a managed care organization that would cater to the entire Greene County in Springfield. Rather, you would have a managed care organization that caters to a very specific small population group. So while they are doing that, while the managed care organization are restricting themselves to offering services to only a small population, what are they basically doing? They are cherry picking, or in other words, they are kind of risk pooling to a crowd that they want, right? So there can be a managed care organization providing services and providing insurance to, let's say, the employees of a certain company, 2,000 employees of company A, and nobody else outside that company. So that means what have they done? They have created a risk pool. They have created a pool for patients, and while they have done that, they have also gathered some information about these patients which they would not have been able to do otherwise, right? So if I am a managed care organization and I want to provide insurance to all the US citizens, how on earth am I going to know about all US citizens, what their background information, their health status? I don't know anything about them. But if I create a small pool and I choose them based on a certain characteristic, remember the paper that I mentioned last time, the Stiglitz paper, Rothschild and Stiglitz, what did they say? They said that you have to kind of choose the risk properties. And you can choose the risk properties based on certain characteristics of these consumers. So here, you are kind of trying to guess the risk properties of the consumers based on maybe their employment, okay, if they work for a certain company, or if they belong to a certain age group, or they live in a certain locality, okay. But whatever be the criteria for picking those patients, it results in choosing only a small fixed group of people. And once you have chosen that fixed group of people, you are kind of, as the insurance company or as the MCO, you are kind of somewhat insulated against the asymmetric information, right? The incomplete information or the gap in information that you had about the patients. So you are somewhat safeguarded against that, first. Secondly, you have a crowd of people, you have a pool of people that you are consistently going to cater to. So you have, as far as the providers are concerned, you have a steady supply of these patients, right? And thirdly, the third benefit that you have is that you can afford to offer the services to them at a little bit lower price, because now you know how risky or how less risky they are. And while you are able to charge a lower price to them, these guys can also benefit by paying that lower rate. Okay. And why are they able to pay that lower rate, or why are these people able to charge that lower rate? The reason being that there is some amount of risk insulation, or there is some amount of bridging of the information gap taking place here. So asymmetric information is reducing, and also the risk that the insurance company has to face, that is also reducing. And so they can offer the patients some benefits in the form of a lower fixed rate. This rate is usually lower than the selective contracting premium, and it is also lower than this fee for service premium. And that is empirically observed in the real world. Yes?
What did you say the first benefit of it was?
The first benefit was risk insulation. So the insurance company now is able to insulate itself against some of the risk that comes with creating a pool of patients. And secondly, there is some amount of reducing or bridging of the information asymmetry or information gap. And since they get these two benefits, they are able to offer a benefit in return to the patients, and that benefit is a fixed lower rate of premium. And this is usually a monthly premium. For managed care organizations, the premium is usually monthly. Yes?
Now, would those providers only accept that particular health insurance from that, or could they accept outside of it?
They cannot. They have to.
Between both of them.
Exactly. They have to only accept that. Okay? So they are kind of tied to a contract, you may say. Yes?
So is MCO synonymous with HMO?
HMO is a type of MCO. MCO is the superset, HMO is a subset of that. There can be 4 different kind of MCOs based on the relationship that you have between the health insurance provider and the health insurance company. So there can be 4 types of MCOs, managed care organizations. And these 4 types, the different types, are based on the relationship that is there between these 2 divisions, the health insurance provider and the health care provider. Okay? The first one is called the PPO, or the PPO, okay, the Preferred Provider Organization, PPO. That's the Preferred Provider Organization. And the distinct feature of the PPO is that, okay, you still have that same organization, and in that same organization you have a healthcare providing division and you have a health insurance providing division, but the relationship between them is that the health insurance provider creates a list of preferred providers. So they are both parts of the same organization, but the health insurance provider, the health insurance division, creates a list of preferred providers. That means the providers that they prefer for whatever reasons, okay? And that creates somewhat an in-network, that creates a network of physicians, or that creates a list of in-network providers and every other provider who is not in that preferred list are out-of-network providers, right? So that means it is only the in-network providers who make a part of that, who make it to that preferred list, and those who are on the preferred list are technically part of that managed care organization, and everybody else who is outside that preferred list are the out-of-network providers, right? Now, in this case, the patient does pay a fixed low rate, that is still there, and the patients are usually encouraged by the insurance companies to go to the preferred providers, that means to the in-network doctors, the in-network physicians, and they are discouraged to go to out-of-network people, okay? But they are not restricted. That means there is no rule that you have to go to the in-network people and you cannot go to anybody who is not on the preferred list. So there is no restriction, but there is only some amount of incentive that is provided to the patients to visit the preferred list of providers, to go to the in-network people, and there are some disincentives that are there if you go to somebody who is out of network. And what is that incentive or disincentive? The incentive is lower user charges if you go to the in-network people, and higher user charges if you go to the out-of-network people. So for the in-network physicians, you have lower user charges, and for out-of-network physicians, you have higher user charges. So in that sense, there are financial incentives for the patients to visit the preferred providers, and there are financial disincentives for the patients to visit someone who is out of network, okay? But please note that there are no restrictions. The organization is not restricting you from going to anybody of your choice who may or may not be on the preferred list, okay? The second type of MCO is the HMO, the Health Maintenance Organization. Oh, did I say 4 types? This will be 3 types, sorry. 3 types. Please correct that. Okay. So the second type is HMO, that is Health Maintenance Organization. In case of the Health Maintenance Organization, once again, you have some integration between the healthcare providers and the health insurance companies, and in this case, the difference is that in addition to having a list of providers, in addition to having people who are in network and out of network and all of that, you have gatekeeper physicians who are basically the primary care physicians. So in case of PPO, there was no role of gatekeeper physicians, but now within the organization, you have some physicians who are primary care doctors and they are gatekeeper physicians, and these gatekeeper physicians must authorize all healthcare treatment. Use or treatment for the patient. So now as far as HMOs are concerned, there you can have 4 types of HMO. Okay, so you can have 4 types of HMO. The first HMO is called the staff model HMO. And all of this is in the notes that I have uploaded already. Lecture note 8, right? So in the staff model HMO, what happens is this organization, this parent organization, the HMO or the managed care organization that we are talking about, that organization goes ahead and hires a list of physicians. So these physicians or healthcare providers are employees of this organization. Okay? So they are staff. By staff, I mean they are employees of this organization. So they do not have any independent practice. They do not have any independent existence of their own. Their existence as healthcare providers are as employees of this organization. Okay? And if you are a member of the HMO, by member of HMO I mean that if your insurance is provided by this particular HMO, then you are entitled only to go to these doctors. Okay? And hence benefit from the lower rate. Now, if you have something which is more critical, which cannot be handled by these staff doctors, then these staff doctors must recommend you to someone outside, to a specialist or to a surgeon. And once you are referred to someone outside, usually you end up paying a higher price for those guys. So that low fixed rate that you had, that advantage can be reaped as long as you are visiting these doctors who are hired by this particular organization. The benefit of that fixed rate is no longer there if you have a critical illness which requires you to visit some other doctor, which is outside this list of employed doctors. Okay? Is that clear? Next, you have the group model HMO. In this case, this particular HMO does not hire a list of doctors, but they enter into some kind of contract or some kind of negotiation with a group practice of physicians. You know what is a group practice, right? Physicians work in a cluster, like some OBGYN doctors will practice at one place at a clinic, or some dermatologists or some eye specialists will all sit in one clinic, right? That's a group practice. You guys know that better than me. So the HMO will negotiate with that kind of a group, and they will negotiate some lower price with them. And then the patients who are a member of that HMO, the patients who get their insurance through this HMO, they will be able to visit any doctor within that group. Okay? So this is a slighter, one notch less restriction than the staff model. Then you have the network model HMO. The network model HMO, this is something similar to the in-network thing that we saw in case of PPO. This is somewhat similar to that. In this case, the HMO will negotiate with a network of physicians. That means multiple groups can be there. Multiple groups of practicing physicians can be a part of that network. So one notch even lesser restriction. Okay? And you as a member of the HMO, if you get your insurance through this particular HMO, then you can visit any doctor who falls in that network. So you can visit any group of doctors within that network and hence benefit from that lower fixed rate of premium. If you visit somebody who is out of network, then obviously your user charges are higher. Okay?
You would still need a referral, though.
You would still need a referral, that is group gatekeeper still has to be there. Okay, that's the first part. And the last one is the independent providers. So these guys are not a part of any group. These guys are not a part of any network. So they are out of network, they are out of group, and they are not directly hired by this organization, but they have, due to their own vested interest, they have come to this HMO, and they have signed up independent contracts with the HMO. So these independent providers have independent contracts with the HMO, and due to these independent contracts, they say that we are only going to cater to the members of this HMO. So we are only going to see the patients and provide services who have insurance through this particular HMO. We will not visit any other patients. We will not provide services to any other patients. Okay? So that means they maintain their own independent entity. They are still independent practitioners, but they are tied by a contract with this particular HMO. Okay? What do you think? What do you think is the downside of this thing? What is the problem with this? What kind of physicians would want to get into this kind of contract?
Ones that don't have a good enough patient base to start with because they're not very good.
Exactly. So there might be a doubt about what kind of physicians want to go into that contract, because they are restricting themselves to the patients that they are going to provide care to. But at the same time, by doing this kind of contract, they are at least trying to ensure that they will get some patients. So these are the people who are concerned about whether am I going to get patient or not if I just practice independently without this contract. So you have those independent providers. So those are kind of the 4 kinds of HMO that you have. So the key feature of an HMO would be these gatekeeper physicians who must authorize, right? And then there can be 4 types depending on how big or how restrictive that list is. Okay? And the third type of managed care is called the point of service plans. The point of service plans. The key feature of a point of service plan is that it is a mixture. It is a mixed model. It's a mixture of the PPO and the HMO plan. It's a combination of the two. That is point of service. Okay. So the feature that it draws from PPO, is that there is an in-network and out-of-network list. So there is a preferred list, which is the in-network, and there is an out-of-network list, right? And you have that same feature that if you go to someone who is on the preferred list, who is in-network, you end up paying low charges, low user charges. If you go visit someone who is out of network, then you have to pay higher charges, okay? But there is also a feature from the HMO that comes here, which is gatekeeper physicians. Gatekeeper physicians. Now, a combination of the two would mean what? In case of PPO, you did not have to go to these gatekeeper guys, right? You need a doctor, you think you need a doctor, you choose whether you want to go to in-network or out-of-network, as simple as that. In case of HMO, you think you need a doctor, you must first go to a gatekeeper physician, and then they are going to send you to one of these people. So everybody who is here has some kind of contract with that HMO. None of them are independent in the true sense. They have some contract with the HMO. The first guys are direct employees, the second guys have a group contract, the third guys have a network contract, and the fourth ones have an independent contract with the HMO. But here you have some people in network, some people out of network. No matter which one you want to go to, you must go through this primary care physician. Then the next step is your choice. Okay? Is that clear? So now, on the exam, will you be able to compare between these different models and these different plans? And can you compare between a traditional fee-for-service and a managed care organization? Can you do that? Yes.
Would all those gatekeeper positions be in-network? Or you can choose an in-network or out-of-network?
The gatekeeper physician? The gatekeeper physician will be always direct employees of the organization in network. So they are not a part of that preferred list at all. They are separate.
So specialty would be either in or out.
Correct. Okay. So we have been talking about, the price and so initially why did we start talking about insurance? If you remember the point where we started, we said that people want to buy insurance because they want to avoid risk. And that the manifestation of that risk is the high out-of-pocket cost of healthcare, right? So people want to insulate themselves against the high cost of out-of-pocket cost, right? So that means you can see that the most important aspect of that out-of-pocket cost, or the most important aspect of that risk, is the monetary cost of any disease condition or any health problems. There's the monetary cost. But please note that while this is the explicit cost that is attached to any health problems that you may have, there is also a time cost that is involved. And what do I mean by the time cost? Let's say you fall sick, you need treatment, there is a monetary cost of that treatment, but remember the time invested on the healthcare input in your utility framework with the time constraint, it is that TH that you had there. So you need to travel to a certain doctor, so there is commute time, you need to wait in line, you need to make an appointment, so there is also that time that is involved. So you are not just putting in money for your treatment, but you also invest time for your treatment. So the actual cost that you incur for any health problems is not that monetary cost, but it is the monetary cost plus the time cost. That is your real cost of treatment. Okay? And we can insulate ourselves against the monetary cost by buying health insurance, but can we do anything about the time cost? Does health insurance help in the time cost? To some extent, yes, because by all these that we have studied under managed care organization, they may be making your process of selecting the provider easy or simple, right? But health insurance does not have any real advantage towards this time cost. Okay? Now, although the total cost is monetary cost plus time cost, these two costs are they work as substitutes to each other. Monetary cost and time cost work as two substitutes to each other. Okay? What do I mean by that? Somebody who values time more than money, that person will be willing to incur more monetary cost and less time cost, correct? If I am a very busy person and my time is extremely important to me, then I would rather have treatment which takes less time, and to compensate for that less time, I am willing to pay more monetary cost, right? And how can I insulate myself against that monetary cost? By buying a health insurance coverage that covers for more of the monetary cost, right? So that means, what am I trying to say? I am trying to say that if a person values time, right, then that person will be willing to pay higher monetary cost okay. And if somebody is willing to pay higher monetary cost, then there is a big possibility that this person will pay higher premium for better coverage, right? And if somebody, the opposite will happen. If somebody values time less, then that person will think that, okay, I can invest time, but I cannot invest money. So that person will want a treatment with lower monetary cost, or in other words, that person will be willing to pay lower premium for the insurance at the cost of having worse coverage, correct? So we can see a direct linkage between health insurance coverage and a person's preference for monetary cost or time cost, correct? Now, what is this time cost? Now, here we can have a dollar value attached to that, to the monetary cost. But what about time? We really cannot place a dollar value for time. We have to think, we have to evaluate time in terms of opportunity cost. The next best alternative use of that time, or what have we sacrificed for that time? The time that I am waiting at the physician's office, what else could I have done with that time? What have I sacrificed during that time while I was waiting at the doctor's office? That is the time cost. It is the opportunity cost, right? And another way of evaluating, another way of trying to add a dollar value to it is by kind of proxying it or by estimating it by your wages, right? If you're an employed person, then this opportunity cost will get a dollar value if I try to evaluate the opportunity cost through your wages. Do you agree? So that means what I'm trying to say is a person having high wages has a high opportunity cost of time. If he waits in the doctor's office, then he gives up more of his wages, right? So there is a high opportunity cost of his time. If there is high opportunity cost of this time, then will he value time more or less? He will value time more, so higher value for time. And if someone values time more, then he will be willing to substitute, he will substitute time intensive treatment by money intensive treatment. So that means he will want some treatment that is less time intensive, that is less time cost based, but he can pay more monetary cost, isn't it? Do you understand what I'm saying? If a person values more time, then he wants to substitute something which requires more time with something that will require more money, because money is not a problem for him. He values time, so he wants to take care of the time aspect of it. So he doesn't want to wait in lines, and to prevent himself from waiting in lines, he is willing to pay more for the treatment. In other words, while he wants to do this, he basically will want to buy insurance with higher premium but better coverage. Is there any problem in this linkage? Okay. And if you just look at the two ends of this linkage, we are saying high wages, a person who gets high wages, and at the end of this link you have the person will be willing to pay high premium with better coverage. So can we say that for high wage earners, it is the high wage earners who will be willing to pay high premium and have better coverage? And it is the low wage earners who will be willing to pay low premium and hence have low coverage? So in that sense, is health insurance a normal good or an inferior good? Say, it's normal. If you have more wages, more income, you buy more. If you have low wages, low income, you buy less. So that's a direct relationship. So in that sense, health insurance is not an inferior good, but it's a normal good, because it's the high wage earners who end up paying high premium and have better coverage. If you are a low wage earner, then you end up paying less for your health insurance and you have a lower coverage. Question?
I'm just thinking, like, afford the luxury.
Because for luxury good and necessary goods, the distinction is based on elasticity, not based on income, right? You can distinguish between a luxury good and necessary good based on is your demand elastic or inelastic. But here we are saying that everybody needs insurance because everybody wants to insulate themselves against risk. But at the end of the day, it boils down to can you afford or can you not, right? So the ones who have better income will be able to afford more, and the person who has lower income will be able to afford less. So now everybody who is in the high income group will be able to get insurance at a better rate, and everybody who is at a higher rate, and everybody who is in the low income group is not able to get that price. So for the health insurance company, there is more incentive to sell insurance to these high wage earners, isn't it? If I am a company and I can get more money from these guys, so I want to sell only to these guys. So what is happening? There is segregation taking place on the part of the health insurance company. The health insurance company is segregating its consumers based on their income. They only want to sell health insurance to people who have better paying capacity than people who do not have paying capacity. So what will happen as a result? As a result of that, more people in the low income group will eventually have no coverage. They will be uninsured people because of that segregation. Do you see what I'm trying to say? The health insurance company has direct incentive of selling to insurance to only these guys. And these people are the high wage earners. Please note that they will keep bidding this price higher and higher and higher and higher because they value time so much. And their wages are rising over time, right? So their opportunity cost of time is also rising. And they are also valuing time even more, and they are willing to pay higher and higher and higher premium. And while they want to pay higher and higher and higher premium, more and more people with not so high income are losing coverage. They are staying uninsured.
Because they can't afford it?
Because they cannot afford it. And that is happening. So you will see that while before the Obamacare, that is exactly why we had the healthcare reform in USA, if you look up at the numbers, then while the number of uninsured people was rising in USA, especially in the 1990s and 2000 till 2004, 2005, when they started talking about the healthcare reform, simultaneously during this time, income inequality in USA was also the highest in terms of numbers. Okay? And that is precisely due to this reason, that there was more income inequality. That means you have larger people, you have kind of polarization of income. You either have low income earners or you have extremely high income earners. There is huge inequality in the pay. So these high income earners can all pay very high prices, and I am a for-profit company. I will only sell to those guys. My market will be restricted to them, and I don't want to. I will discriminate against the people who cannot pay that high premium and not sell the goods to them, not sell the insurance to them. So what will happen eventually to those people? They will lose coverage. They cannot afford, and that is exactly what happened. So what was the obvious answer? The obvious answer was to bring in a policy which mandates the companies to sell insurance to everybody. You cannot discriminate based on income. You cannot discriminate based on health condition. That is where we will end today's class, with that diagram where we are saying that, okay, fine, now the government is saying that mandate health insurance, but after mandating health insurance, next what? And we have done this diagram in class when we talked about the demand supply chapter, when we were doing review questions 2.